conducted teaching in Gaza in 2013. So there's our Palestinian connection is there. And it's presented at many local and national conferences, and it's a review for multiple journals. And as I said, he's a radiologist in private practice in PE, or Kabeha, I should say. I actually get to see a lot of your reports because patients come from PE to Cape Town for kidney transplants. So nice to hear you speaking.
So, we talk about prostate cancer because, imaging has become much more important in prostate cancer, and prostate cancer is also not uncommon at all. It is the leading cause of cancer in men. In fact, prostate cancer is the commonest cause, as I said, and it's the second leading cause for cancer death in men. Prostate cancer is having said that, it's usually a slow-growing cancer, so aggressive treatment is not usually needed in many cases, and overall about 96% of men who are diagnosed with prostate cancer are still alive 5 years later. So that's one positive with regards to prostate cancer. So old men who are at risk of prostate cancer, this risk increases as you get older. So prostate cancer is a malignancy starting in the gland, and most commonly the peripheral part of the gland, called the peripheral zone. The central area of the gland is called transitional zone. This is the area where BPH starts. So everyone knows what BPH. So BPH starts in the central part of the gland. I'll show you the anatomy just now. The commonest screening tests we all know about are PSA and the digital rectal examination. So those are still the starting points for any prostate examination. And biopsy is the main tool for diagnosis. So as I was saying about the anatomy, you can see the transitional zone. This is the coronal image, and that's the surgical image. So that's where your BPH originates, and then peripheral zone is where prostate cancer majority begins. So you get prostate cancer starting in the transitional zone and central zone as well, but less commonly. So this is how you look on MRI, those areas. So this is an X-ray image here showing your central zone, transitional zone. That white area is your peripheral zone. So that's the area where most cancer starts. And you can see the detail you can see on MR. You can see the neurovascular bundles. You can see on the left image the seminal vesicles. You can see them quite clearly. So extra prostatic extension can be quite well demonstrated on MRI. In terms of the pathologies that we see in the prostate, there's a whole host of pathologies. Benign pathologies, the main two are really BPH and prostatitis. The others are all much less common. In malignancy is mainly adenocarcinomas, and that, as I said, mostly in the peripheral zone. Other cancers in the prostate are way less common. So why do we do prostate MRI? Why has it become such an important examination now? The aim is to maximize the detection of clinically significant tumors, minimize the detection of insignificant tumors, minimize the number of men requiring biopsies, minimize the number of biopsies, and then the morbidity from and complications related to biopsies. Has this got rid of the DRE? Not quite. We still need to do that screening. Everyone can't get a prostate MR. So unfortunately, we still have to do the digital rectal examinations. I think. When has prostate MR has been around not too long. Prostate, they started looking at prostates around the late 80s, but properly investigating the prostate only started in the early 2000s when the diffusion studies came on. So from about 2002, they started doing prostate MRs. The first studies were only done probably around 2004, 2005. So in South Africa, we're probably doing it for maybe 10, 15 years prostate MR. Having said that, prostate is still an expensive study. It's not available everywhere. There's still contraindications to a prostate MRI. There's obstacles. Patients with pacemakers can't get MRIs. The pacemakers have to be switched off. Or the patients with a hip prosthesis will get a lot of artifact for your prostate MR. So there's all limitations. It's a longer study. We require a stable, still patient. We need MRI compatible equipment, but it's still gives you good clinical and anatomical detail. It's no radiation, and it's a starting. It has an important role in picking up cancers early and using the screening tools to filter out your patients, and then from there you can go on to managing patients better. And as I said, this decreases the number of patients getting biopsies and the number of biopsies and the morbidities from biopsies. So when we talk about prostate MRI, we talk about multi-parametric MRI. So that is basically assessing the different tissues in the prostate. We use different sequences. So the tissue structure, you use the T2 sequence, the density of the cells. So that changes with malignancy and with normal tissue. We use what's called the diffusion weighted imaging for that. And then to assess vascularity, we give contrast. And that gives us an idea of a more vascular tumor, more aggressive tumor. So those are the basic three sequences we use for a prostate MR. So prostate MR is a bit of a longer study, but if we give contrast, we can get a study done under 30 minutes. Without contrast, we can get it probably about 20 minutes. So prostate contrast is not given to routinely, but it's becoming much more commonly used because it can differentiate the borderline cases and more aggressive cases. And when you do prostate MR, you want a patient that's well prepared. You don't want too much gas in the colon. You don't want too much bowel movement, so you give things like buscopan to decrease that. Prostate MRI nowadays can be done on a 1.5 or 3 Tesla MRI. The new 1.5 machines actually give good detail. And endorectal coils initially were used. It's no more requirement. The studies are good quality without endorectal coils. And it also decreases the discomfort of the examination. So what are the indications for prostate MR? Definitely first indication is prostate cancer detection. Prostate MR, as I said, assists with the biopsy. Before, most of the biopsies were done blindly. And before, most of the biopsies were transrectal, which is basically transfecal, so that there was always the risk of more infection. The transdermal biopsies have become now in vogue, and they're no more as costly as before. They can be performed in doctors' rooms with local sedation, without the GA, and as I said, there's less infection. So prior to MRI, the urologists were doing blind biopsies up to 32 biopsies of the prostate. So now we can do targeted biopsies with MR. So we do the MR, and then after we do the MRI guided biopsy. The MRI guided biopsies are not still being done in South Africa, but still we use the MRI, and the MRI can be fused with your ultrasound, and you can go for targeted biopsies. So you don't do 32 biopsies anymore. You can do just to the left gland or right gland, a limited number of biopsies. So the first studies for prostate MRI were done the main study was done in 2018, the precision study, which compared MRI targeted biopsies versus standard biopsy. So the control arm, they just did the standard biopsy technique, and in the other arm, they did the MRI guided biopsies. And the results basically fulfill what our aim was. It showed that MRI decreased the number of clinically significant cancers. It showed that prostate MRI increases detection of clinically significant cancers. You're seeing there the Gleason scores. So let me just touch on that. What's a Gleason score? So Gleason score was derived by Robert Gleason in the 60s. It's a histological grading, so it's made up of two values. So basically, a Gleason 6 is a low-grade cancer, where 9 and 10 is a high-grade cancer. And other results from the study were the prostate MRI decreased the number of manual lead biopsies, decreased the number of biopsies per patient. So everything what we wanted, that the first study showed that prostate can go towards achieving that. The second study was done, big study was done in 2022, and that was to assess whether the screening with PSA and then targeted biopsies was an effective way. And that also, the results of that study showed that avoidance of just the routine systemic biopsies was much in favor of MRI directed biopsy for screening was definitely better for patients. It it reduced the risk of overdiagnosis by half. And from that also we got the 2-year interval for follow-up MRI patients that were borderline or had equivocal case was safe because of the slow growing nature of most prostate cancers. So with regards to the biopsy approach, targeted biopsy approach, so nowadays most urologists are sending the patient for the MRI and they have to do targeted biopsies. And you're seeing there the PIRATES. PIRATES is a grading system for prostate cancer. We'll touch on it just now, just to give you an idea. So every lesion that we see in the prostate, we grade with the PIRATES score. So PIRATES 3 lesion is basically an equivocal lesion. So they don't tend to biopsy every PIRATES lesion. So depending on the PSA density, it's a higher PSA density, or if the patient is a high risk patient, those patients go for biopsy the PIRATES 3. Whereas you get PIRATES 4 and 5, those are lesions that look like malignant on MR. Those patients all get biopsies. So as I said, it's a targeted biopsy, and systemic biopsies are only done if there's a negative scan and the PSAs continue to rise, or if it's a high-risk patient. Here's the image of how you can fuse the ultrasound with your MR. So those dots are like a guide, and you get the MRI image and you superimpose where your lesion is with the ultrasound, and you can do then transperineal biopsies, more targeted and more limited. You need to do a biopsy of the whole, as I said, of the Bateman suite of the prostate gland. Other indications for prostate, so identification or exclusion of significant biopsy, CA in biopsy naive patients, local staging. Prostate MR is very good at assessing extracapsular extension of the malignancy, to assess the neurovascular bundles. From the study, you can see that MRI has a high specificity, but poor sensitivity for local staging, and even the extracapsular extension is superior to other imaging without the endorectal coil use. Prostate MRI is also good for helping surgeons now doing robotic surgery to doing nerve sparing surgery. These studies showed that. Another indication for prostate MRI is for active surveillance. So what's active surveillance? So active surveillance is basically patients who have at least 6 prostate cancers. So, and with very low PSA density, you just want to follow up those patients. So those patients, they do routine PSA and prostate MRI at intervals. And there's actually a grading system, the precise score for following up these patients. And if their PSA is increasing or you find any changes in the MRI, those patients will then go for biopsy. So it's also got a role in active surveillance and decreasing aggressive and invasive management of patients that don't really need it. Other indications for prostate MR would be before and after radiation therapy, after radical prostatectomy if there is elevation in PSA, patients who are got severe BPH and are going for embolization, patients with severe prostate pain that no other cause can be ascertained. For any focal treatments, and I said MRI guided biopsy, we're still not doing those, but overseas they're doing MRI guided biopsies. So that's another indication we do a prostate MR. I was speaking about the PIRATES score, so basically that's a universal language that wherever you go in the world now, you tell them a PIRATES 3, a PIRATES 4, the urologist, so anyone will know what's PIRATES. So it's a universal grading system. It stands for prostate imaging reporting and data system. Simple algorithms and tables. You can see if I tell you PIRATES 3, you know where is it, and it's the prostate is basically broken up into 16 regions, and with using the sequences, the T2, the diffusion and contrast sequences, every lesion in different zones of the prostate are given a score, and you can see from that it's graded 1 to 5. 1 is basically a normal prostate, 2 is benign lesions, so a BPH nodule would be a prostate PIRATES 2 lesion, and then the PIRATES 3 are the equivocal ones. So those will either biopsy or follow up, and then the PIRATES 4 looks malignant on the MR, definitely biopsy that. PIRATES 5 is a prostate PIRATES 4 lesion that's greater than 15 millimeters, or a lesion that shows features of extension beyond the prostate. And just got a few more words on the MRI. So as I said, the different zones, they've got different sequences that give you the information. So the peripheral zone, the diffusion weighted sequence is the most important for that zone. And in the transitional zone, with the T2 sequence is most important for that zone. And then vascularity, contrast, when we give contrast, that also helps us in sometimes stratifying different lesions. So how does the prostate look on MR? This would be, so you can see that white area, that's all your peripheral zones. That's the main area I said where prostate cancer arises. That's your transitional zone. And you can see in this corners here are the two neurovascular bundles. So you will see extension into neurovascular bundles. There will be your rectum there, and anteriorly you get your base of the bladder. This is how BPH looks. So if you look at this image, so BPH it starts in your transitional zone. It's made up of all these nodular areas, and it expands your transitional zone. So BPH in effect also is almost protective against cancer because it squashes your peripheral zone. So you have less of a peripheral zone, so you've got a bit less risk of getting prostate cancer. You've got extreme BPH. And then this is images of prostatitis. Sometimes it can be very difficult in separating prostatitis from malignant looking lesions on MR, but that's where the contrast sometimes can help in all the diffusion sequences. I don't know if it makes sense with these images, but yeah, these are images of prostatitis. How does a malignant lesion look on MR? So we're talking about the Pirates 4 and Pirates 5 lesions. So there's a lesion there in your right peripheral zone. You can see it's lower T2, so the gland is nice and bright, as I said. So a lesion, malignant lesion will be dark. We do diffusion sequences, so you can see that's how it looks on diffusion. You give contrast, it will enhance. So this is a Pirates 4 lesion. A Pirates 5 lesion, basically a larger lesion, and this one is also an extension beyond the prostate. After you give contrast, you can see that. You get cancers in the transitional zone, as I said, they're less common. So this is the cancer starting in the anterior part of the transitional zone, extending beyond your prostate gland. So these are just a few examples of how cancers look. And I was talking about extraprostatic extension. So in this patient, you can see there's definitely features of extension beyond your prostate into the region of the neurovascular bundle. So this patient, this will affect your staging, the grading, and the surgery. So where are we with regards to MRI of the prostate and the pilot staging? We are basically, MRI has a high sensitivity for detecting cancer, but the specificity in the number of lesions picked up is still a bit low. So we haven't reached where we should be, but still at the moment the best imaging for the prostate. All the different organizations are still recommending prostate imaging for cancer. There are some limitations. The radiologist expertise, Pirates 3 lesions always become a problem, whether we should biopsy or not. Just speeding up a little bit, let's see. So what are the pitfalls of prostate MR? Poor slide quality, poorly prepared patient, poor knowledge of the anatomy. If patients get a biopsy, we don't do an MR within 6 weeks after it because the blood can affect your detector. So basically, if you have a prostate biopsy, don't do the scan within 6 weeks. Just a few words on the T staging. Prostate definitely helps with assessing this. This is just a schematic showing the different T grades. So if you have to look for prostatic extension, these are what you look for. And that as you go down towards the right, it shows a higher risk of getting extraprostatic extension. Seminal vesicle extension can also be assessed on prostate MR. So you can see on this image that extension into the seminal vesicle, and this is on your coronal image. A sagittal image going to your seminal vesicle. This is just another more detailed image showing your T staging that can be assessed with MR. Quick case here. So a 67-year-old male with a high PSA. On examination, there was a right-sided lesion. So you can see this lesion on the right side. This feature suggestive of extension beyond the prostate. That's the lesion. On the other sequences, the diffusion sequence, you can see on the right side with contrast. The lesion shows. So that's a Pirates 5 lesion extending beyond the prostate gland. Post-treatment recurrence, if there's a PSA increase of 2, we do a MR. MR is very good at showing also recurrence in the prostate bed, post-prostatectomy and following the radiotherapy. studies have shown this, that MR is an excellent technique for showing local recurrence, but it doesn't show the distant metastasis. So bone mets, lymph nodes, MR is not the best at showing that. We'll come to other studies for that quickly. There's also a grading system for showing recurrence post-treatment. So we have the PIRATS, this is the PIRR for showing recurrence. This is the case showing post-treatment. This is a patient with right-sided prostatectomy for prostate CA follow-up. They had a patient with rising PSA. So this was the initial scan showing the lesion. So post-prostatectomy, there was a nodule which was seen in the prostate bed. This was on diffusion sequences post-contrast. So it shows up the recurrent lesion very nicely on prostate MR. We talked about assessing metastases in the bone and lymph nodes. That's where the role of PSMA PET is a big role. So this is your nuclear medicine imaging. So what's PSMA PET? PSMA stands for prostate-specific membrane antigen. So it's higher expression on the cancer cells. So we get radioisotopes that are labeled with PSMA. So they attach to the prostate cancer cells and any metastases. And it's extremely valuable in showing metastasis. It's basically the gold standard for imaging of prostate metastasis, and even first, it has a role in helping with recurrence in patients that have different types of cancers, not the common adenocarcinoma that don't show up in MR. PSMA PET can help with that. It's definitely superior to CT scan and bone scanning, picking up lymph nodes and bone metastases. I'll just show you a quick case to show you two cases to show you the value of PSMA PET. So here's a 72-year-old patient with a high PSA on examination the normal left side. MRI showed a PIRAX 5 lesion. It was a high-grade Gleason 6 lesion. So as you can see on this, so there's a fused. So there's your MRI images. There's the lesion there. That's a CT scan. So CT scan you can barely see anything. So these are MRI images fused with your PET scan. So you can see how it shows up on the PET scan, the lesion. But you're not seeing the metastasis clearly on the MR. So when you move on the PET scan, you can see there's bone metastasis there. There's further bone metastasis in your ischium there, you can see. So the PET is very important in showing bone metastasis and lymph nodes. Last patient, so 68-year-old patient, Gleason 8 prostate cancer patient, had prostatectomy, radiotherapy, now rising PSA, did a PSMA PET scan. On this CT scan, I don't think so anybody would have called anything. There's nothing you can see. Right, to tell you that's a lymph node, that tiny thing, no one would have worried about that. But when we did a PET scan, look how it lights up. I mean, everyone would have written off that it's just a normal lymph node or vessel, but it lights up like a light bulb with PSMA set. So despite the size of that lymph node, it's infiltrated lymph node. So that's the value of PSMA PET. It's saying in the coronal sequences you can see that lymph node. So PSMA PET is definitely got a value in staging and follow-up cancers and picking up metastases. So that's in conclusion. Imaging has definitely become an important part in the management of prostate CA, influence of treatment, guide regimen management, and prostate cancer being the commonest malignancy require reliable imaging, and prostate MRI is proven to be that, and definitely better tolerated than mammograms. And yeah, with PSMA PET, you've got another tool to image the prostate and the text. Thank you. That's a really good time.
We're going to take questions at the end just to make sure that we get through all the speakers. Okay, so the next speaker is Dr. Imran Parker, who graduated in 2002 from UCT and then did his training in radiation oncology at Christian UCT from 2006 to 2009, and until 2012 he stayed on as the head of the breast cancer unit, and since 2012 he's been at a private practice at the Miller Med Hospitals, and he's also going to talk to us about prostate cancer, but now the management, so it's a prostate cancer thing. on a personal note, he's my wife's nephew.
Thank you everybody for attending. So just to follow on the theme of prostate cancer, it would be nice to do the imaging and then do the overview of how we actually treat our patients. The face of our patients we don't see when we do the digital rectal examination. My background in prostate cancer is similar to my colleagues over there. Any male can be affected, especially over the age of 40. It's the commonest cancer amongst males, which is surpassing lung cancers. And the stats are rising. You can see 320,000 newly diagnosed cases in 2008. For South Africa, unfortunately, we don't have a cancer registry, so we don't have exact numbers of how many patients are diagnosed. One of the biggest screening tests that you can use is the PSA. Now, we're talking purely about screening here and only using the PSA, and it's a topic of debate because in this setting, I mean, we're not doing the digital rectal examination, we're only doing PSA. So, should we be doing this? Yes or no? It's a debate over there. We've got to consider cost of screening, patient anxiety, benefit versus harm, and also the risk of overdiagnosing patients. So, should PSA screening be used in asymptomatic males? Okay, and this is not doing digital rectal examination, only doing PSAs, no other form of examination. The 2012 European Society of Medical Oncology recommendation is no, we should not be doing that. We should always combine it with a physical examination and a history as well. And that was data used from 6 randomized trials and 3 meta-analysis. If we are going to use it for asymptomatic males, make sure that the patient is well suited, okay? And always discuss the pros and cons with your patients. Personally, would I do it? Yes, I would. I would avoid the digital rectal examination. So, this cost of screening, and this is where the data come from. And this is looking again at European studies. PSA screening randomly on men with median follow-up for over 11 years. Again, these are asymptomatic males, and the absolute reduction in mortality is 1 death in 1,000 men. So, when you're looking at the cost of it, you're looking at 1 death in 11 years, you've got to screen 11,000 patients and detect 37 cancer patients. Based on that, recommendation is not to screen PSA in asymptomatic males. So just some basic pathophysiology. We know that prostate cancer is testosterone driven, and that your reduction of testosterone being from the testes and the adrenal glands. And this is important because it becomes our targeted treatments as we go along. Some simple signs and symptoms of our patients, we know frequency, nocturia, hematuria, dysuria, and all the other symptoms. The last one I put in over there, bone pain, if it's metastatic disease. Unfortunately, lots of patients are coming late, presenting quite late with severe back pain or hip pain and diagnosed with metastatic prostate cancer. So our treatment options, treatment really depends on the stage. Okay, and here we have surgery, chemotherapy, radiotherapy. We have 2 forms of radiotherapy that exist. The one is called external beam, we'll catch on that later, and the other one's radiotherapy, which is a wonderful form of treatment. And then there's also the symptomatic control for more advanced cancer patients. Okay. Basic staging tests. PSA is important. We need histology confirming the subtype, as my colleague pointed out. Most cancers are adenocarcinomas, however, the few that are picked up would be squamous, lymphomas, or other subtypes, and that's totally different management. We then determine the Gleason score, exactly as you said earlier. Is it less than 6? Is it 7, 8, 9, and 10? Basic chest X-ray or detecting lung metastasis. We also do bone scans, PETs, or DWIPs is a whole body MRI scan. I've left out MRI scans over here deliberately because that's we've already seen patients, they have MRI scans prior to their diagnosis. So exactly PET scans are wonderful tools detecting metastatic disease, and you can see exactly where the arrows pointing to lymph nodes, which you would not normally picked up on simple plain CT scans. Another example of a PET scan with a met in the spine over there, and I've got another one over there. And they really are very, very useful tools picking up metastatic disease. In addition to bone metastasis, it also helps a lot with nodal metastasis also. So, as mentioned earlier, we'll skip through this one quickly. Stage 1 cancers localized only to the prostate, so stage 2 and stage 3 includes extension into seminal vesicles. Stage 4 would be involvement of metastatic disease, including the bladder locally. Okay. When it comes to staging, and this is important for patient management as well, we classify our patients into low, intermediate, or high risks. The lowest patients are your low Gleason scores, less than 6, a PSA under 10 or T1, T2. The intermediate risk group is one step higher, Gleason 7, sometimes 8 as well, PSA 10 to 20, and T2s or higher. And a high Gleason score, high risk of Gleason's 8, 9, and 10, and PSAs are greater than 20. Okay. This is important because with low risk prostate cancer patients, you can have active surveillance, as we saw earlier on as well. Patients still must have regular PSAs, regular digital rectal examinations, and if their PSA does increase, you're going to have to require the biopsy of that. This was confirmed with the PIVOT and SPCG trials, where they randomized radical prostatectomy to observation, and in terms of mortality at 12 years, there was not much difference between the two, 2.6% absolute difference. However, with surgery, there is a greater morbidity. When it comes to intermediate and high risk, here it's a bit more difficult because you can really use surgery or radiotherapy. The two is very similar, the outcomes are the same. They have a massively different side effect profile, and it's important to discuss this with your patient and to individualize treatment as much as possible. We sometimes use surgery more for the intermediate risk groups and not so much for the high risk groups. Radical prostatectomy is a surgery of choice, but then do we do lymph node dissections? That becomes a big one. So with an intermediate and high risk, lymph node dissection as a high associated morbidity does provide surgical staging, hence can influence further management going on, but to what level to dissect is no answer on that one. For high risk patients, we should rather do forms of radiotherapy, whether that be external beam or brachytherapy, which was your seed implantations of the beam. So I'm just skipping forward a bit to the high risk patients and intermediate risk and how we actually do this. We CT our patients, make sure the rectum is emptied. We then contour the prostate gland, and the dose of radiation is planned according to the prostate of the margin, and we keep our bladder doses to a minimum. That's an example of a radiotherapy plan. This is one of the older forms of radiation. We called it 3D conformal. Since then, we've moved on quite a bit. We now use IMRT and VMAT. So you can see the area in red is the high dose area. The area in blue is the low dose radiation. So we really spare the surrounding tissue as much as possible going forward. Okay, skip that. The advantage of the radiotherapy with external beam is also that we can include our nodal areas and position. Okay, go over here quickly. So this is our nodal area over here. And we're including that into our radiation field. That will be administered by the LINAC. It's the LINAC accelerator. Patient treatment is about 10 minutes per day. However, treatment is about 7 weeks on a daily basis. Okay. With our intermediate and high risk patients receiving external beam radiation, it's also important for them to have androgen deprivation therapy. Okay, and this is important because as we go back to our pathophysiology, we want to know that we know that it's testosterone driven. So we want to give this cut down testosterone in the body as much as possible, decrease the size of our actual tumor, decrease the size of our radiation field, and hence decrease the side effect profile with better patient outcomes as well. Androgen deprivation therapy is also the first line of treatment in stage 4 disease. So if we look at actual studies, we can see that using antigen deprivation therapy with radiation offers a improvement in overall survival, as opposed to not using it at all. When it comes, again, as mentioned earlier, the size of the prostate shrinks with antigen deprivation therapy. As they become smaller, our side effect profile becomes smaller, we have less tissue, less radiation goes onto the rectum as well. So intermediate and high-risk patients can also receive brachytherapy, and it's really for a selected risk patient. The volume of prostate is important, and that is determined on our MRI scan. We use the implantation of radioactive iodine seeds, which emit low dose over a long duration of time. We can also use high-dose brachytherapy with a radium source that is not available in South Africa, unfortunately. And we can use the brachytherapy as a single modality or in combination with external beam radiotherapy. So when it comes to brachytherapy versus surgery, there's multiple trials and multiple meta-analyses have been done. The overall survival and disease-free survival is very similar between the two groups. However, we have better side effect profile. We have less likely to develop within the incontinence with brachytherapy, and we have preservation of the less erectile dysfunction with brachytherapy as with surgery. You should really be individualizing treatment as much as possible. So that's an example of how we do brachytherapy. Patient is taken to theatre, put in the 40-minute position, the rectum is emptied, an ultrasound probe is inserted into the rectum, and under direct visualization, we insert the seeds, and you can see the actual size of the seeds, very, very small seeds, and we use anywhere between 40 and 80 radioactive seeds to insert into it. Okay, very, very tiny. And if you were to X-ray our patients afterwards, that's what it looks like. Multiple seeds all in the prostate, and it offers really a good form of treatment for our patients for early disease. Stage 4 disease. Unfortunately, when it comes to stage 4 disease, our emphasis is focused on quality of life of the year. It's important to remember that we're not going to cure our patients with stage 4 disease, but we can try to control as much of the symptoms as possible, whether it be pain control from bone metastasis, brain metastasis, or anywhere else. As mentioned earlier, antigen deprivation therapy is our first line therapy. We can also use bisphosphonates for bone metastasis, and chemotherapy agents going forward as well. Unfortunately, the survival of stage 4 cancer is not that good. Prostate cancer, stages 1, 2, and 3, we end up with a 95% 5-year survival. Stage 4, unfortunately, that drops between 37 and 50% 5-year survival. So then it becomes quality of life going forward. Thank you very much.
So unusually we're running ahead of time. Thank you, Imran, for keeping it short and sweet. Well, in fact, we've done 2 cancer talks, so let's take some questions around. Where's the mic? Any questions on prostate cancer?
I think for those who didn't hear, the question was, how common is it to have chest metastasis? So if you're talking about lung metastasis, less likely. Bone metastasis, a lot more likely, depending on the actual presentation and the stage of the patient. High PSA is more likely to have bone metastasis in presentation. So if you have a patient with a PSA greater than 20, your likelihood of bone metastasis is quite dramatic.
seed that you leave them in permanently, or what's the duration? Or?
Yeah, so the seeds stay in permanently. They only have a 6-week lifespan, so the half-life goes down very, very dramatically. So from the time of insertion to 6 weeks later, the dose is zero. The top-off is low. They really are low emission. So you can be safe for these patients to be around pregnant women, around children. They're not going to be emitting any radiation outside of the body. So from the actual prostate to about 2-3 centimeters beyond the prostate, the dose is marginal. It's almost zero over there. Seeds staying permanently. The number of seeds depend on what the dose we want to achieve. So as I mentioned, we can use brachytherapy seed implantation as a monotherapy. We can also combine it to a lower dose with external beam radiation as well.
Is it a once-off treatment?
That's a once-off treatment, correct.
Is there any place for MRI scans to be used for screening in asymptomatic high-risk patients?
We could do it, but I'm saying it just comes at a cost. I mean, MRI is such an expensive study. If you are a high-risk patient or a family history or very high PSA, but I think we have to do some sort of PSA. We don't have patients walking in and saying, "What prostate MRI?" I think it's more costly and very dirty of MRI. So I guess you can pay.
Sorry, on that point, do medical aids pay for MRI? If there's an algorithm, yeah.
It's got a neurologist with high PSA that I think is going to be.
Okay, so it's covered by medical aids if it's referred by you from your neurologist.
Is there a risk of secondary radiation-induced cancer, like a secondary cancer by using prostate?
Sure. The question is there a risk of secondary radiotherapy-induced cancers in our patients? Not really. Now and then you see the odd patient, and we have one at the moment who's had a conversion from adenocarcinoma to a squamous carcinoma. But we're talking about low risk, low numbers, small percentage. Radiotherapy to the prostate, brachytherapy or external beam is very, very localized, and we're not touching any other organs around it.
Okay, this is to either one of the speakers. Is there any link between prostatic calcification and cancers? And do we need, as primary care doctors, when we see calcification in the prostate, is that something to worry about?
I know we see prostate calcifications very commonly on a CT scan or anything. And I think it could be maybe a previous infection, maybe previous hemorrhage or something that can then calcify. It does affect the interpretation of the hemorrhage. There's a lot of calcifications, but I don't know any link. I know we like to test it. So we get microcalcifications in the testes. That's got a link with increased cancer, but nothing I know of prostate.
Yeah, what I understand from my experience in family medicine, that we start with the patient with PSA. After that, with ultrasound. I don't know after that what I will call it. Neurologist job, yes. After that, CT, and after that, MRI. So MRI, if it's benign, I don't know, stop or continue with the investigations or stop at that level. Or if it causes compression, to have any system or something like that, we can do operation. So we reach MRI when there is metastasis or high risk patient, as you said. Yeah? So we don't start it because it's very close, as you said, and it took time to do it. Maybe we more easily do biopsy and ultrasound procedures. What do you think?
I think it ultimately depends on what's available in your environment. I'm saying if you don't have MRI availability, then you're going to go that route. But I'm saying if we have the MRI availability, it definitely be a better route because ultrasound's got limited what you can detect on ultrasound. Basically, with ultrasound, you're going to see your volume, you're going to see if it's enlarged, you can see it's compressing your bladder. You can't really, it's very much more difficult to pick up a lesion on ultrasound. And as you saw some of the CT images, it's almost impossible to pick up a lesion within the prostate and CT. You just see a big gland, that's about it. So in terms of detecting a lesion within the gland, that's where MR is compelling. I mean, if you don't have MR ability, then you're going to do systemic biopsies, and you'll still then pick up the cancers at least. So I think it's what's available to you to do that way, to follow that pathway.
But it has to MR to extend your operation.
Yeah, because it can see extension, you can create the tumor, you can decide when you do active management.
Not the same.
Yeah.
Yes. The question I have is that we know the relationship between testosterone and prostate cancer. Now, in the lab, recently, in the last few years, we see a lot of patients supplemented therapy with libido and things for other reasons. With that risk that we know now, should those patients be talked to about the risk, or is there baseline PSA? What's the role? Because we're seeing a lot of patients now on their testosterone.
No, definitely. Those patients need a stern talking, to be honest. I actually had a patient years ago who had a high risk prostate cancer. He had antigen deprivation therapy followed by radiation, and he decided this is not for him because it was interfering with his body building, and he wanted to go back to his testosterone supplements. Presented 2 years later with widespread metastatic disease. So those patients should be fully aware that that's going to happen.
Just your thoughts on the prostatic artery embolism that's been mentioned in the
So the embolisms we're doing for BPH, I mean, I don't do it, we don't do it in our center, but I'm saying that's the place for prostate embolism. They treat for BPH, so the gland gets very large. Instead of doing surgical removal, we embolize the arteries, and then your prostate will just shrink and will decrease symptoms. So I don't have any experience with that.
Is my understanding of the current recommendations correct that routine PSAs should not be done unless there are symptoms?
So the understanding is you should not do routine PSA as a screening tool in asymptomatic patients. There should be some sort of symptoms that accompany the patient, and given that it should also be used with an examination. So that's the important take on. Examination is important and symptoms, and then you can use your PSA.
What would those symptoms be?
Sorry?
What kind of symptoms? Some kind of symptoms.
Symptoms. Dysuria, frequency, your BPH symptoms basically. So all those symptoms have to be accompanied. So they can see it.
In the aging population, the screening of PSA, we see patients over 90, but we do the screening of patients over 90. Do we still do 2-year PSA?
So the question was a good thing.
Patients over the age of 90 and PSA testing. Is there any?
I think over the age of 90, we're not going to do much on those patients. When you look at, as we mentioned earlier as well, prostate cancers are very slow growing cancers. They're not highly aggressive. So even a patient with a rising PSA at the age of 90 may even live 2-3 years without any form of treatment before anything does happen.
So, to find out what is the expected time period for a patient having hematuria after radiotherapy?
So depending on what form of radiotherapy we use, if we use brachytherapy, we can get hematuria lasting for about 2 weeks, more or less. With external beam radiation, also about 3 to 4 weeks you can have hematuria. But it should be decreasing, it should not be getting any worse. The concern is that if your patient has had brachytherapy and they're continuously having radiotherapy, maybe one of the seeds has migrated into the bladder, or maybe into the close to the proximity to the urethra as well. With external beam radiation, it's a bit more controlled, but you can get a spillover dose into the bladder, causing a cystitis in the bladder that would bleed from there. So those patients persistent hematuria, they may need a cystoscopy to see what's happening in the bladder.
Just to ask you, with HIV patients, we tend to screen them at a very early age, between 35 and 40. And we are using PSA because there's a high rate in black males of getting prostate CA with HIV. Is that the correct way to go?
Well, to be honest, in my practice, I haven't seen that many HIV positive patients with prostate cancers. So with this characteristic, I'm not too sure, but the data still says asymptomatic shouldn't be screened. And I don't think HIV is an associated condition with prostate cancer. HIV associated malignancies would be lymphomas, leukemics, and Kaposi sarcoma more than prostate cancers.
Okay, last question.
Is there a false positive for PSA?
And there's always a false positive of PSA, but I think that's why you can't use a PSA on its own. It must be accompanied by a clinical examination and history as well.
One last thing, I think, also, just for the benefit of the colleagues, I think for the benefit of our colleagues, I think there are some measures that need to be taken before you can do a PSA test on the patient. So, including the medical history, family history, and all of that, you also need to advise the patient that your perception activities that can increase your production of prostate-specific antigen. And some of them can include might be constipation, arms closed, riding a bicycle, ejaculation prior. So when you're going to see a patient coming in for a general exam and you're testing to do this cases, we actually do that PSA. Advise them these are activities that you should avoid so we get less chances of having a false positive.
Yeah, sure. There was actually a small study that was done, and it also indicates that when you send a patient for PSA, wait a couple of days after you've done the digital examination. Don't do the digital and send them immediately for PSA, because then you get exactly get false positive and wait a couple of days.
Okay, on that point, I think we'll end of that session. Thanks, guys. I think we've thrashed out prostate cancers quite thoroughly. And now we're going to move slightly higher